Hello everyone. For this section, we're going to talk about schizophrenia spectrum disorders. So this is going to be, of course, schizophrenia, but also other disorders that kind of fall in line with schizophrenic type symptoms. So we're going to address those later. We're going to talk about there are personality disorders that are related to this, but that will be covered in the personality disorder unit, not in this one. And so as you can see by this picture here, I'm sure you've heard a lot about different things concerning schizophrenia because it's one of those things that's kind of sensationalized, but it also has very severe, it can have very severe effects. The psychosis can have very severe effects on someone's functioning and perceptions of the world. It can almost seem scary in some of the movies we've seen. And so what I've posted here is a self-portrait by an artist formerly known as Brian Charnley. He passed by taking his own life, unfortunately, in 1991, but he's well known for having schizophrenia and kind of doing these different self-portraits as he progressed through his illness. And so I've linked a website about him where you can view his different portraits and everything there and how they've kind of changed as he moved through his diagnosis. So I just thought that would be an interesting little side note case study you can look at and see how that applies to some well-known people. But what we're going to talk about with this unit is describing the signs and symptoms of schizophrenia and related psychotic disorders, describing risk factors and the development of schizophrenia, looking at controversies associated with clinical high-risk approaches. So just kind of looking at which risk factors are more notable and why are they considered high risk, and describe the treatments that work for some of the symptoms of schizophrenia because it's very difficult to treat. We're going to examine that issue further. So where I wanted to start, I know this is a hodgepodge of information, but you may have heard of the movie A Beautiful Mind with Russell Crowe. Again, there are a lot of movies out there that address schizophrenia and schizophrenic type disorders, and so I just put that picture in because it's talked about in our book. But I also wanted to talk about other things you may have heard or found interesting about people with schizophrenia. Sometimes they have disordered or disorganized thinking. And so this picture right here with the notebook of the writing, this is an example of a writing of someone or an entry of someone with schizophrenia, how their thought patterns kind of progress in their writing. It's very random. It jumps back and forth. It's almost paranoid. Now, this doesn't have to happen to everyone who has schizophrenia, but again, we're going to see those individual differences. I just wanted to put this out there to kind of demonstrate, the application of the different symptoms we're seeing. It's one thing to hear about disorganized thoughts and writing and speech, but it's another thing to see it in its entirety. And also, I don't know if y'all heard about this Miriam Carey. It was back in 2013. I was finishing up my undergrad, and she was shot outside of the White House, and it was found that she was trying to break into the White House because she believed that President Obama was stalking her. And so that's a very paranoid symptom of schizophrenia, and it was a well-known case because of the severity of what happened. And she also called herself the prophet of Stanford, and she had a lot of delusions, false beliefs. And we're going to talk about how all of these things in this section. So what we want to talk about with schizophrenia and related psychotic disorders are some of the symptoms that surround this spectrum. So we're going to look at delusions, which, as you may or may not recall, are going to be false beliefs. And they are going to be closely held, right, really tightly held and entrenched beliefs that someone's going to hold despite evidence to the contrary. So these could be I can't say this word, excuse me, persecutory, see, I'm not perfect, y'all. But think persecution. So they're going to think that people are targeting them or attacking them. That's what they mean by this. Like, so-and-so is stalking me, or, my dad wants me dead, yada yada, those kind of thoughts. You're going to have thoughts of grandiosity, maybe. This is just this idea of they are so wonderful and they have all this clout and all this ego, but it's really unearned. So this could be something like believing that they are the next coming of Jesus Christ. And it sounds kind of silly when we say that, but it's actually, it's happened. There's also referential delusions, and this is just the idea that unrelated events are related to them. Like maybe the sun rose on this morning in a certain way and the sky was painted in that direction to give them a sign, or it was made just for them. Something like that. Right? It's a little outside. I know some of us may think that way in a romantic sense, but it's just this idea that unrelated events are referencing them. So maybe that song on the radio was made for me, kind of thing. And it's outside of the normal thinking where we think those things. And we're going to talk about that a little more in depth because, again, with these types of delusions, they are going to affect daily functioning. So if you believe that a song's on the radio was made just for you, it's probably just because you really like the song. These people really believe it was made for them. And that's just an example. With schizophrenia and schizophrenia spectrum disorders, you're also going to look at hallucinations. So these are just perceptual phenomena that aren't really present. There's no sensory experience or there's no stimuli in the environment, but these people are experiencing a perceptual phenomenon. So commonly, this will be hearing sounds that aren't actually there and negative hallucinations. So these auditory hallucinations are like people talking at them all the time. Okay, these could be hearing voices in your head consistently, and it's not the same as you or I when we hear the voices like think things out in our head. These are actually sound like outsiders in their head talking to them, yelling at them, being negative with them, second guessing them, degrading them, berating them, kind of thing. You're also going to see disorganized speech and odd behaviors. So their speech patterns are illogical, kind of as you can see if you read through this brief writing entry here, but also odd behaviors, maybe dressing in odd ways or acting in odd ways. And what we mean by odd is acting outside of like social norms to the point of impairment. Again, for the sake of our class, I'll try to keep this more condensed because we do have an abnormal psychology that you can take that will take the semester to uncover these things, but I'm trying to condense it for our Psych 150 course, give you a nice preview. You're also going to have abnormal motor behavior. So catatonia is this idea that people put themselves in odd positions or react kind of illogically to like their environmental stimuli or how their body should react. So it's kind of like in every scary movie featuring a mental health institution where you have the person like crawled up in a chair or holding a really weird position or walking in a really weird, scary way. That's the sensationalizing of that catatonia. You also have negative symptoms. So negative symptoms are going to be a lack of something. So think of negative here as, our mathematical equation. So what's being taken away? In the case of schizophrenia, it's flat affect, so taking away the emotions they feel or blunting them. And also the ability to read others. So that's social cognition. There's going to be a deficit in how they read others. Now, this chart is actually in our text, and it's wonderful for explaining the different spectrum disorders. And so we're just going to go through these really quickly for any salient symptoms or things that might be confusing. So schizophrenia in and of itself, well, let me just condense it. It's going to have a nice condensed version of the DSM's information concerning schizophrenia spectrum disorders. So I would use this as a reference point for a case study assignment, should you need it. Do a great infographic. And so you're going to have schizophrenia itself. So you're going to have 2 or more of the following for at least 1 month. Hallucinations, delusions, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. Impairment in 1 or more areas of function, social, occupational, educational, or self-care. So if someone has schizophrenia and it's severe enough, sometimes, let's say they're having auditory hallucinations on top of negative symptoms, and they're not able to interact with people because they're consistently hearing voices in their head and they can't discern between what's quote unquote real and what's occurring in their head. So this can impair their social functioning, or one area of function. It could also impair an occupational area of functioning. If they're maybe working in customer service, hearing voices in your head as you're working with people, either in person or over the phone, can be detrimental to your job functioning. So for a diagnosis of schizophrenia, these symptoms have to occur for at least 6 months. And for schizophreniform disorder, it's going to be similar to schizophrenia, but the time duration is going to be less. So at least 1 month, but less than 6 months. So it may come in more bouts, whereas schizophrenia is quite persistent. Schizoaffective disorder is just talking about, this is kind of like schizophrenia mixed with a major depression or manic episode. So we talk a bit about this in mood disorders because different disorders will be changed based on what they are co-occurring with. If someone has schizophrenia symptoms but not depression, that's going to be one diagnosis. But if they have a major depressive or manic episode, it's going to be classified as a schizoaffective disorder. And so this person will experience delusions or hallucinations for at least 2 weeks when they are not having a depressive or manic episode. If you don't know what a depressive or manic episode is, please review the mood disorders PowerPoint and video. Again, I'm quickly going through these, but if you have any questions, feel free to email me. I don't like to read off the slide when I know you all are wonderful readers and note takers and are going to read this section. Just want to give you a quick review. Delusional disorder. So as you can tell by the name, it probably has something to do with holding false beliefs. So the presence of at least one delusion for at least a month. So key thing here, the operative word with this, even though they're having delusions, the person has never met the criteria for schizophrenia. So they have not met any of these other symptoms, or, well, at least in total, they haven't met the schizophrenia diagnosis as classified by the DSM. They just have the delusion. And the person's function is not going to be impaired outside of their delusion. So maybe they have delusions of grandeur. They think they are awesome, the bee's knees, or the next coming of Jesus. Well, they may think that, but if that's the only impairment in their life, that they think they are the next savior, then that doesn't necessarily qualify them for schizophrenia. They would have to be accompanied by the other symptoms listed under schizophrenia. And also the duration of any depressive or manic episodes have been brief, related to the duration of the delusion. So if they do have any depressive or manic episodes, or that low mood state, or that euphoric mood state, it's going to be shorter in time compared to the duration of the delusion. The delusion is going to be very enduring, as you see 1 month of having that false belief. Then you're going to have brief psychotic disorder. So one or more of the following symptoms presented for at least 1 day but less than 1 month. So it's very brief, right? Delusions, hallucinations, disorganized speech, grossly disordered or catatonic behavior. And then you're going to have attenuated psychotic disorder. So again, these are just, we're looking at the psychotic. Attenuated just means reduced. So think of the symptoms that kind of follow with schizophrenia, but they're going to be attenuated forms, so reduced forms. They're not going to be as salient. Again, you could read this, so I'm not going to go through it, but when we diagnose these different things, I will make a quick note to you. It's going to depend on the clinician. Yes, we have systematic information to make this diagnosis, but there's also different individuals kind of practicing it, so how they collect that information and the method they use is going to determine, the proper course of action, their diagnosis. Maybe they'll kind of like a medical doctor. They'll consult with another therapist or psychologist. Usually the psychotic disorders are dealt with by psychologists or psychiatrists, and there is a difference. So just know that while we have the systematic criteria, it's not exactly perfect, much like a medical diagnosis. You have to gather your evidence to kind of support which of these symptoms you find salient. And that's what we're going to do in our case study activity, just to give you kind of an idea of how that works. And again, we're going to talk about therapeutic approaches later. But there is cognitive neuroscience to schizophrenia. And why is this important? It's because the bottom line is there are going to be problems in the person's cognitive functioning. With schizophrenia, we actually can see the physical impairments that this disorder can have on the brain. And rather than this being these changes in our brain structure of people with schizophrenia and schizophrenia spectrum disorders, these changes in brain structures can often precede the diagnosis. And so that's why I say it's a risk rather than a result. These things can kind of tip us off who is more likely to develop this if they have these certain characteristics in their brain, such as reduced gray matter or difficulty firing signals in the ventral striatum and the anterior prefrontal cortex. So that's important because those areas of their brain are going to fire when they see something salient or something that sticks out in their environment. We talked about consciousness, how things grab our attention. Well, that kind of makes sense because things in the environment and things in someone's head, when they have schizophrenia disorder, they start blending together sometimes. And so it's hard to delineate the effects of the environment as well as the effects of the voices they're hearing in their head or the hallucinations that they're having. It can sound pretty scary, but it's not all gloom and doom. There are treatments to try to abate some of the symptoms, but we can't really cure schizophrenia as a whole. And so I think the most important thing to grab out of this section, there's a lot of talk about different parts of the brain. I think the most important thing to get is how it affects the actual structure of the brain, the actual functioning of the brain. It's because a lot of these disorders, they do have roots in how our brain is functioning. There are some maladaptive patterns, and so it's important to understand that, especially such as cognitive function, because when someone loses that cognitive function, it tends to become this vicious cycle. Okay, so let's say they have reduced social cognition. They're not really able to read people or infer people's intentions. So maybe they don't interact with people as much. Well, when you don't interact with people as much, you don't get to practice reading other people and inferring their intentions. And it becomes this kind of cycle of not gaining those appropriate social skills as well as the inability to read other people. And you just keep spiraling to further that deficit in their social skills. And so some risk factors for schizophrenia are genetics. There could be a genetic component because we've seen a lot that I think it was said first cousins or closely related relatives of first cousins can kind of be indicative of schizophrenia. So if you have a relative with schizophrenia, the closer related they are to you, the higher the risk. But it's hard to kind of identify those specific genes that are going to kind of hint us, to which gene is responsible for schizophrenia, because the genes affected are also shared with bipolar disorder and seen in cases such as autism, so other conditions. It's kind of hard to pinpoint that exact genetic component, but we're getting an idea. Whereas environmental factors that have been associated with the development of schizophrenia, again, this just means that these factors were found to be correlated with the development of schizophrenia. If you have any of these, this does not guarantee you're going to get it. It just, we find a strong correlation between these two. So problems during pregnancy, such as gestational diabetes, and difficulties in birth that limit the oxygen given to the newborn's brain, or hypoxia, the amount of oxygen available. So it's low, that could affect, brain functioning and development later. People who tend to have older fathers, there are a slew of issues that are associated with older parents. You will learn that if you go on to take developmental psychology. Cannabis use, cannabis is a hallucinogen, so that, may have something to do with it. We're still kind of looking at the effects of marijuana or THC on our brain and our brain structure, such as the frontal cortex, the frontal lobe, excuse me, and where we do most of our thinking, the prefrontal cortex. Children who tend to grow up in urban settings, as well as minority ethnic groups. So it becomes a question of, is it something about that environment, or maybe the stress associated with that environment? Because we talked about the diathesis stress model and how certain stressors can kind of activate certain disorders. And finally, treatment. So typically what we're going to see for schizophrenia is, unfortunately, as of right now, we don't have a cure in totality. It's kind of managing the symptoms. And so if someone has hallucinations, for example, they may be taking antipsychotic medications. So there are typical antipsychotic medications and atypical ones. So typical ones were dated back about 60 years ago, discovered on accident, right? And they're going to block a certain dopamine receptor. Remember dopamine, that neurotransmitter we talked about being responsible for the feel-good feelings? Well, these are going to aim to reduce hallucinations, delusions, and the disorganized speech. So again, kind of abating some of those side effects or symptoms of schizophrenia. And they can have some distressing motor side effects, and so that's where the atypical psychotic medications come in, because they have similar results in reducing symptoms, but they're not going to affect motor functioning as much. But there's still a risk of weight gain, cardiovascular illness, diabetes, type 2, and mortality. So you kind of have to weigh, because again, when we talk about psychological disorders, not all medications are going to work for everyone. It's kind of looking at each person and almost guessing, in a sense, which drug would be best for them at what dosage. Unfortunately, it's not like you're tested on guinea pigs, because it's founded in research. They're not going to just give you a medication and try it willy-nilly. It's going to be evidence-based diagnosis and process. So don't think that if you are on certain medications with your therapist that they're just trying to give you anything and just guessing which one will work best for you. No, they're going to use evidence-based practices and to systematically kind of figure out which medication will work for you. But again, outside of our purview. And there is a recently developed therapeutic technique for people with schizophrenia and schizophrenia spectrum disorders, and it's called cognitive enhancement therapy. I've actually included a link to it from the Cleveland Clinic, because it's really interesting how they explain it and its efficacy. Because while these antipsychotic medications are good for reducing the hallucinations and delusions and those negative side effects, it doesn't help in reducing the cognitive impairments that people may have if they develop schizophrenia. So what this therapy aims to do is kind of utilize these interpersonal, really close activities and kind of develop individual activities for the individual. That was a little redundant, but I'm going to say it anyway. They're going to develop personalized activities to help someone improve their social functioning. So maybe they'll give them like a case study in an interaction between two people and have them practice, what's being said in this conversation, or what do you think person A expects from person B. Something like practicing those social skills. And there's all different forms of it. They do group therapy as well. And it's very one-on-one and very in-depth and interpersonal. And it's just to help them improve the functional outcome and their social cognition, to make them more aware of kind of the practice, those skills that typically depreciate with the progression of the diagnosis. And that's all I have for now, but make sure you watch the next lecture on therapy.